My passion for critical care really lies in the fast-paced nature of the discipline of medicine, as well as just that special role of being present with families and their children in their time of greatest need.
PICU is the kind of job that you have to be 100% committed and sure that this is the right career path for you. There's a lot of different things that go into making a great fellow, but what I'm really looking for in the applicant, I want someone that's coming with a fire in their belly. I want someone that is coming and they're ready to put in the work.
And the clinical duties can be demanding. Within the daily grind and the hard work with patient care, I think successful fellows take the opportunity to ask questions and to seek out the opinion of their attending physicians.
I don't expect them to come knowing how to do all the procedures. I don't expect them to come knowing all the medical knowledge components of pediatric critical care. I expect them to come and want to learn and want to be here and want to be present. And when you're there and you're dedicated and you've got that fire, the families notice that. It's obvious to everybody that interacts with you. And then those families want that fellow to be their doctor too.
Our first year is more clinically heavy. This is sort of an immersion learning where we throw you in and you really get to take care of a lot of super sick kids, and then that gets you up to speed so you can start to learn and kind of hone your craft the second and third years.
I think we do a really great job, especially the first year, getting your foundation in pediatric critical care and making you be a really solid intensivist. As an intensivist, one of the best skills that we can have are effective communication skills and understanding how those communication skills work and interact with various players in the critically ill patient.
We have a really nice collaboration between the intensive care unit teams, our ECMO specialist, and our surgical team as well. It takes all of those different teams and their various expertise coming together and working together to help these children survive their very delicate and very serious illness.
And so I think that multidisciplinary component of our field is more pronounced than it is in a lot of other specialties because of the emergencies and the acuity of the moment. So really, we spend a lot of time with the fellows working on some team building. How do you effectively communicate with the nurse? How do you make sure that during crisis, what you say actually makes it to the patient, and that so the nurse hears it, and that you know that the nurse has heard it? And we discuss this closed loop communication. One of the great opportunities our fellows have at our program is the simulation opportunities that present itself. It's a rapidly growing field, and pediatric critical care is one of the specialties that's leading the way. And here at Riley, we're so fortunate to have a group of investigators that have really established themselves as leaders in simulation. Our fellowship is set up to have increasing responsibilities, and therefore the fellow role on the team changes as they progress through their fellowship. A typical first-year fellow, the expectations are to be present on the team, to learn from the attending, to actively participate in rounds, to actively participate in the education of the residents and medical students. As they grow and gain confidence and knowledge through their fellowship, the responsibilities and expectations change. And so by second year, I expect the fellow on service to really be running rounds. I expect 90% of their education to the residents and medical students to be critically care-driven kind of education. I expect them to be able to triage and deal with consultants, and I expect them to need me a little bit, but really they're running the team.
We definitely want to instill a sense of self-efficacy in the fellow, a sense that they can do it, that they can take ownership, that they can drive their learning, that they can lead a team.
Each team is separate with its own attending, its own fellow, and a group of residents or nurse practitioners. In the pediatric critical care side, the teams are composed of almost entirely residents as the frontline providers. We do occasionally have medical students rotate through, And then on the cardiac ICU side, the team is predominantly composed of nurse practitioners with the fellow and the attending also on that team. Each team has its own pharmacist. Teams have rotating through dietitians, social workers, chaplains, and then obviously our important allies of our bedside nurse providers and respiratory therapists. By the third year, the expectations have been moved to the point that often the attending is always available and assigned to the unit, but it is common for the attending to leave the unit a significant amount of time. Often the fellows will run rounds completely independently without the attending present in the rounding circle. They are responsible for the education of the residents almost solely at that point, and then also responsible to interact and have conversations with our consulting teams.
One of the things I cherish most about the Pediatric Critical Care Division at Riley is the diverse backgrounds of our attendings. We have an outstanding group of intensivists who have trained at many prestigious fellowship programs all across the country. So by the end of 3 years of fellowship, our trainees will have worked with all these different attendings, each of whom has a particular approach to a problem. And at the end of those 3 years, they can more or less kind of gather what they like from each attending and develop their own style.
By the time they leave, I really feel like our fellows are ready to hit the ground running in any attending position that they were to take at any program in the country.
To know that we made the difference for those kids and their families is something that keeps all of us going from day to day.